Good afternoon, everybody. I'm happy this afternoon to welcome Dr. Robert Savage from the North Coast Hospice, who's going to discuss what's new in healthcare delivery. Dr. Savage?
Okay, thank you very much. I'm a guy who wears two hats. This morning I was working intensive care at Scripps Encinitas, and I'm going back there as soon as I'm finished, so I apologize for getting here a few minutes late. And I'm also a medical director, associate medical director with the hospice, so I work in the two different areas. And in the last 10 years, there have been a lot of changes in medicine, and I find as patients come into the hospital, they're often surprised by how things work. So I thought I would like to sort of introduce you to the concept of what's different in medical care, and also what I think is important for patients to do in terms of helping direct your care, because in the past we've always thought of the doctor as being the one who tells us what to do, but I think more importantly you need to have a concept of what you want done, because there are a lot of options as you get down the road of medical care. So number one, I'm just going to go back to where people or where doctors are and who's who. Does anybody in here see a doctor that is called an internist? We got internists, okay? And how about a specialist of any kind? A heart doctor, a kidney doctor, a rheumatology doctor? Okay, so the idea is, where do these people come from? And this is the way medicine has been practiced for a long time. We've got doctors that go to med school, and everybody has to go there. And after med school, then you go to what's called an internship. Now, important concept here, the doctors in training as interns are not internists, and there's sometimes a confusion about that. So an intern is a doctor immediately out of medical school who is being supervised by resident doctors or an attending doctor. And the only time you might come in contact with interns is in a teaching hospital. For example, if you were admitted to the UCSD Medical Center, you might have interns involved as part of your care team, and they would identify themselves as such. After internship, there are different ways that doctors go to become a specialist, and we've got surgeons that go one way, and the surgeons can then branch out into a different variety of specialties, including lung surgery, heart surgery, general surgery, vascular surgery, and so forth. And then we've got the internal medicine training program. And internal medicine is basically adult medicine. So these are doctors who are trained in all aspects of medical care, including heart, lung, and so forth. And this is a 3-year training program, and when they have completed this, they are called internists. So an internist then is often a doctor that we will be seeing in the community and taking care of our problems. If we have a more complex problem in a certain area, then the internist may refer you to a specialist, a cardiologist, a pulmonary specialist, a rheumatologist, and so forth. And that comes from this kind of training. The internal medicine training is completed. You can go out into practice as an internist, or you can have more advanced training. And the more advanced training is what's called a fellowship. And in the fellowship training, that's where we get our cardiologists, and you can think about any organ system in the body, and we have a specialty for it. Neurology is kind of separate. That comes over here, and that would be the nervous system. But, so we've got all these different specialists, but what I want to talk about and kind of weave into the talk is 2 new specialists that have really come into prominence in the last 10 years. And that is going to be, let me pull this up so I can make it more legible. And those 2 things are the hospitalist and then the palliative care specialist. Does anybody have any dealings with hospitals? Anybody? We've got 1, 2 people, and 3, 4. And what So what the internal medicine training program has done has said, well, we've got kind of two avenues that internists may want to go in their practice. In the old days, and that's when I was practicing for a number of years, until about 10 years ago, all internists did both things. They saw office patients, and then they saw their patients in the hospital. So normally when you saw your doctor in the office and he thought you were sick enough to go to the hospital and admitted you, then he would be the one who followed you along in the hospital and took care of you, and then again saw you after you left. That doesn't happen anymore, and a lot of people are surprised. I would say 95% or more of the time, the internists who practice in office practice do not engage in hospital practice. So what we have developed in is a group of doctors called hospitalists who are only practicing in the hospital. So these doctors, and so if you're admitted to a hospital, these would be doctors you've never seen before for the most part. And the way these doctors work, they are internists, so they have specialized training in internal medicine. To a lot of us, they look pretty young. This is a new specialty, and a lot of them are young. They're not interns. They are specialized physicians who, for the most part, are very competent and experienced. So the hospitalists work on kind of a regular schedule, which is, again, unusual for doctors in the past. They'll come in at 8, they'll go home at 6. While they're there, they're your doctor. When they go, then somebody else takes over. So it's important to kind of be aware that this may happen in the hospital. Now, some of the practicing doctors in offices will come in and visit their patients as kind of as a social visit and may have some interaction with the hospitalist doctors. But for the most part, the hospitalist doctors are directing the care. So it's important that you kind of make it very clear to the doctor, the hospitalist, what your needs are, because they're not going to know you the way your regular doctor does. The other concept and other specialty, which is relatively new, is called palliative care. And the general medical model in the past has been, we are going to treat people until they drop dead. You know, we'll keep doing more tests and we'll keep doing more procedures. And, you know, for some people and in some situations, that may not be best. When people, for example, and most commonly in palliative care in hospice is involved in cancer patients who have gotten to the point where the usual cancer treatments are no longer effective. But palliative care can also apply to people who have other more chronic conditions. For example, heart disease, lung disease, kidney disease, and are reaching kind of the end of the line, or maybe not. And you know, again, the important thing is what your desires are in terms of how much you want done and what you want done. And really important to communicate that to your attending doctors. In the hospital setting, occasionally you may have a palliative care doctor come in. And this does not mean that you are at the end of the line. This means that we want to help you clarify what your goals are. You know, how much treatment do you want, under what circumstances do you want it, and I think this is a really important part of the dialogue between the patient and the physician. So, how does this thing work in the hospital? You see a different hospitalist. The hospitalist may be the same person who comes on 3 days in a row or so, and then somebody else comes in. We fortunately have a pretty good system of communication in which we pass on the information from doctor to doctor. But again, this makes it, to me, increasingly important that you sort of keep track of things. In other words, what your medications are. Don't hesitate to ask questions. If something doesn't sound right to you, if you don't understand why something is being done, if you're being sent for a test you don't understand, it's not only okay to ask questions, it's really important for you to ask questions. So at night, we got another specialty doctor called a nocturnist, another new concept. So this is a doctor who comes in and is there all night and is kind of looking after things at nighttime. Now, what are the benefits and what are the drawbacks of the hospitalist system? The drawbacks, I think, are pretty apparent. The doctor doesn't know you. So as opposed to your doctor who's known you for 20 years, knows your condition, knows your personality, these doctors don't know you. So they've got to, there's an initial getting to know you process and you getting to know them process and feeling comfortable with them. There is the possibility of some lack of transmission of information as one doctor changes to another. And then there's always the process at the end of your hospital stay. The hospitalists usually do a very good job of discharge summary and communicating with your primary care doctor what's happened and what we need to do for follow-up, what's expected. But that's a place where things can break down. The benefits of the system are that you've got a doctor there all the time to be available to look after any problems that come up. In the past, if the patient was not doing well, the nurse had to call. The doctor may have been on the golf course. The doctor may have been in the office, overwhelmed by patients and not able to respond as quickly as would be desirable. Now you've got the doctor there in the hospital who can come and evaluate things and take care of things right away. So that's, to me, a big plus. So just to go through what happens when you come into the hospital, you might come in a number of different ways. Your doctor in the office might say, man, you're sick, you need to go in the hospital for testing or treatment, and then refer you to the hospital, and you generally kind of go through the emergency room in that situation. You may come directly through the emergency room. You're feeling so bad, and you call your doctor's office, and they say, if you're feeling bad, call 911. I'm sure you've all heard that message. And so that may be another route by which you get to the hospital. In the emergency room, the doctors will go over you very carefully in terms of what's wrong, what your possible needs are, and will decide whether you need to come in or whether this is something that can be treated as an outpatient. From the emergency room, you may be sent off to different areas of the hospital, x-ray for testing. If there's something urgent, sometimes patients go directly to surgery from the emergency room. Then from there, we've got different areas of the hospital you can go to, depending on your level of care needed. For example, intensive care. If you're really sick, you will go to intensive care. Not so sick, you might go to the general medical floor. Once you're in intensive care and get better, then you go to the general medical floor prior to discharge. Now, what are some of the new things that we're dealing with in the hospitals? Number one, the question I've got on this handout here is they sent me to a different hospital. Why does that happen? And what may happen, you come in the emergency room, you're evaluated, they decide you need to come in the hospital, and then they say, oh, but you're contracted with an insurance company that says you've got to go to Tri-City rather than Encinitas, or you've got to go to San Diego. So, therefore, very important, if you have a really strong desire to be in a local hospital or a particular hospital, that when you sign up for any insurance, any Medicare supplement policies, for example, you be sure that they will allow you to be admitted to the hospital you want to go to. Very important. Because I see this every day. People are surprised. Why can't we stay here? You have to move. And the only circumstance in which we don't move a patient is if they're too sick to be transferred and have to be put in intensive care. And in the intensive care setting, same thing. The patient gets better, and then we have to transfer because of the insurance requirements. So be very careful when you sign up for an insurance, what sort of restrictions they have on where you might be treated. The hospital seems to be wanting to get rid of you quickly. In the past, we had kind of a leisurely thing where, okay, we'll keep you for a couple of weeks and make sure you're stronger. Now you come in, and the first thing they're looking at is how quickly can we get you back out. And does anybody know why that is?
Money.
Money, yes, money. Because in the past, the hospitals used to be paid by the day. So there's no incentive. Hey, we'll keep them an extra day, we get paid an extra day. Now, especially with Medicare, a patient comes in with a particular diagnosis, for example, congestive heart failure, pneumonia, heart attack, they are given a certain payment. And that's it. So, if you have to stay there for 2 months, obviously there's some modifications on that. But the general concept is that the quicker the hospital can get you out, the more economically efficient it is for the hospital. So to that end, they've developed a lot of resources to make it safe for the patient to leave and to make sure that the patient leaves with the right instructions and doing the right thing. At Scripps Encinitas, we have now what's called a navigator. And everybody gets a navigator, and that navigator helps you navigate the systems. In other words, what are your needs after you are discharged? And that navigator is there to make sure that you are set up with everything you need. The hospital may even send a nurse out to your home to check and make sure that things are doing well. And the reason for that is that there's a recent ruling by Medicare that for certain diagnoses, if a patient bounces back to the hospital, has to be readmitted within a certain period of time, the hospital doesn't get paid. So they want to make sure that you are going to do well once you're discharged. And to me, that's a good incentive that we make sure that the patient is as healthy as they can be when they go, and that we make sure that we have got them on the proper medications, that they understand those medications, and most importantly, that they continue on the medications they need to keep them from coming back. Recognize what kind of problems might be an indicator that things are not going well. And again, a nurse may call you and check and make sure things are doing well. So we talked about that. And then, so once you're in the hospital and ready to go home, what are the options? Option number one, you're good enough to go. You had an acute illness, you're strong enough to go home. You don't need any extra care at home. Option number two might be that you need some assistance at home in terms of maybe some nursing care to check on you, and this is something the navigator can help you with. Option number three, perhaps because of the acute illness, you've become so weak that you need some rehabilitation before you can go back home. And they would arrange for your stay in a rehabilitation facility. That part of it is paid for by Medicare up to 3 weeks. So as opposed to regular nursing home care, which is not paid for by Medicare, the rehabilitation section of it is. So that's something to think about. If you're on the fence and saying, I don't know whether I'm strong enough to go home, maybe a few days, maybe a week in rehabilitation is going to be all you need to get you back and ready to go. Other options when people go home. Number one would be hospice. Are we at the point where we're saying, I've been in and out of the hospital a bunch of times, this person is really sick. Do they have perhaps an estimated survival of 6 months or less? Then hospice is a wonderful way to get a lot of help at home and a lot of care at home. And often we're wrong about that estimation of 6 months, and we have people who recertify and recertify and recertify. But these are people who obviously need a lot of assistance and are able to get it through that mode. I think just the take-home message, and the most important thing to me is that you realize that you have options, and that you be sure you express your needs and you stand up for what you think your needs are. I had a very informative interaction with a patient and his wife recently. A poor man with cancer who's been put through a lot of treatments, and he's just going downhill, and finally came in with an involvement in his brain, and the surgeon came in and said, you have to be operated on, and we've got to do this tomorrow because I'm going on vacation. and the family is distraught. They spent the night crying, not knowing what to do. And when I went in and talked to them, nobody had ever told them before that you have options. The choices are yours. And they said, we know he's not going to survive. We know he's not curable. And I said, well, you need to really think about and talk to your other doctors about what really is the best thing. In other words, what are the expected results of a procedure? What are the expected consequences? And finding what can we all do to assure that you have the best quality of life not just another medical test. So in that regard, I think, there's a new form, which I think you've heard about before, the PULSE form. It's in your packet. And it's important to think about, because basically what it says is, it's directing your doctors to make the choices that you make in terms of caring for you. In other words, to acknowledge the choices you make. There are lots of options toward the end of life. Do you want to be put on a ventilator? If so, how long would you want to be kept on a ventilator? Indefinitely, short time, and see how things go? If your heart stops, would you want the doctors to make efforts to restart it? And under what circumstances? Would you want a feeding tube in the event that you couldn't swallow or take nutrition? These are all very important questions, because at the end of life, I think most of us end up in a situation where we have to make those decisions. So I've got Chris from the hospice here, who's in the back, who is an expert on the PULSE. And I think I would like to have her come up and just answer questions, because this is not just a form you zip through and fill out. This is something that requires some thought, because it's important. And this form is acknowledged everywhere. It's accepted everywhere. She can tell you about how best to make sure that it's accepted in terms of where to put it and how to deal with it. And something you need to sit down and talk to your doctor about. Doctors, for the most part, are very reluctant to talk about this question. It's not an easy question, because in a way patients, I think, assume that you're saying they're not doing well when you're saying this, but the time when you're doing well is the time to make these decisions. And your doctors are rushed, they don't want to sit down and take the time to go over these forms, to go over these issues, but these are very, very important issues. Does anybody have any questions? Yes, sir.
Let me see if I can frame the question. But, we see a lot of ads on TV, say, ask your doctor.
Mm-hmm.
And the doctor that you're to ask, the presumption is the old family doctor. When I was a child, we had Dr. Cameron. He brought a bag and he came to the house and he knew the family. But today, the doctor is somebody you might see once every 2 years for 10 minutes.
That's right.
So, and he's not going to be there when you're in the hospital. Is there any merit, really, in even having a doctor of that sort? What is the meaning of that relationship?
Well, that's important. I think, if you have ongoing medical problems, then I think it's obviously very important that you have somebody that you feel comfortable with, someone you trust, someone who is acting in your best interest.
Where do you get that?
Well,
It's not always your friends or family.
no, you may have to shop around. You may have to shop.
I'm in Kaiser, but before that, I went to Dr. Bangs here in the village.
Yeah.
Dr. Bangs didn't know who I was. The Kaiser doctor, I'm in his computer. So there's that aspect of this.
No, and I think you're referring to something important that we've lost in medical care. One of the things that I really enjoyed in my private practice before was knowing my patients and having that special bond with them and being able to help them when they needed help. And I think if you can find someone like that, boy, you ought to stick with them, and you may have to look. Because I think you're right. Medicine has become, to some extent, increasingly dehumanized, with the computers especially. And I often hear patients complain that they saw the doctor's back as he's entering information in the computer, and never really interacted with them in terms of why they're there and what's important.
I'm not sure that that's bad, though. You may get better care.
Well, no, I think the computer aspect of medicine has its positive things. You've got, number one, notes that are legible if you're doing them electronically. You've got information that is then available to a wider group of doctors who are taking care of you. So these are good things about the computer aspect. But the depersonalized nature, I think, at the very basis of medicine is that relationship between the doctor and the patient.
That's very important.
Yeah.
Does somebody else have a question? I don't know how that's.
Yes.
I have a question. I have a question about the hospital practice.
it is apparent now that people are going into the emergency room and are being told they need to be admitted to the hospital. And they are admitted to the hospital, and then after that, they're discharged. And then the hospital doesn't put on there that the medical necessity was to be admitted to the hospital. They say you were in for observation, and the insurance, Medicare, and everybody else will not pay for observation. Can you comment on that?
Yeah, and the payment aspect of it, I can't comment, but what happens with observation, we have certain requirements imposed by Medicare in terms of what justifies an admission. And if a patient is kind of in that gray zone and you don't want to send them out, then they would be admitted as an observation patient, meaning, well, they may go home tomorrow, or they may turn out to have something more serious than we think and be then changed to admission or inpatient status.
The trouble is the patient's not told that.
Yeah, they should be.
They aren't.
Yeah, they should be. Yes, ma'am.
Say I have an accident and I don't have this form with me,
Okay.
and they pick me up in an ambulance. Now what happens?
That is a problem, because without other information, then we as medical professionals are obligated to do everything possible.
Well, that's true, because my doctor told me to get a bracelet, because I wanted a tattoo saying, "Do not resist."
Yeah, I thought about that myself.
And he said, "No tattoo, get a bracelet." And he wouldn't give me a prescription for a gold bracelet, but I put the money out myself.
Yeah.
And they put me in the ambulance, and not once did they look at it.
They don't.
No, they should look at that immediately, because that has information that's really
No,
important.
when we almost was there at Sprint, which one hospital? They said, no, it doesn't matter what the bracelet says. We have to do what we can to keep you alive.
Yeah, and I think that's unfortunate. And Chris can tell you with the pulse how to, the best we can anyway, make sure that that is acknowledged.
Well, I was very unhappy.
Yes, ma'am.
I want to add on the hospitalist. When you go in, like from here, emergency, and you have to go to the hospital, and this person, doctor, takes care of you there, how soon does he get in touch, or does he, with your primary doctor to watch you?
It's kind of individual, and I know I've seen some of them talking to the primary care doctor frequently during the hospital stay. Sometimes important information is obtained from the primary care doctor, so I know they do that. But I think it depends on the hospitalist. Some of them are more judicious about doing that kind of follow-up.
And if you are aware, can you bring this up, see that they do get in touch with your?
I absolutely would bring that up, yeah.
Okay. Thank you.
Okay. Let's say that you're in a skilled nursing facility, and once in a while the physician phones in an order, and the nurse, from her experience, feels that that may not be quite appropriate. Is the authority of the physician so great relative to that of a nurse that the welfare of the patient is secondary, or is there a procedure to correct that sort of inappropriate action?
If a nurse feels that a medication is inappropriate or dangerous, then she has every right to refuse to administer it. That's under her license. So the gray zone comes when it's not quite so clear cut. But if something is felt to be dangerous or inappropriate, a good nurse will say, "I'm not going to give this," and we'll call the doctor.
And does she have an avenue of authority to go through, or is she dependent on that sole doctor?
No, she has a medical director at the facility that she can contact, and he can override anything that is felt to be inappropriate. Yes, sir.
Can you comment on the effect of patient care with 30 million new patients and no new doctors coming in?
Again, I think it's going to result in shorter visits. doctors who know less about their patients and less personal interaction.
Well, I just read in Investor Business Daily yesterday that some of the hospitals now, effective October 1st, will be given bonuses for avoiding operations like hip replacement and this sort of thing on seniors. If they do fewer of them, then they get a bonus.
Okay, that's something I don't know about.
I'm just wondering, are we going to get less and less care now?
I don't know. That's a good bit. That's a concern, and that's why you need to continue to be your own advocate. You know, when you feel that somebody is trying to do something that's not to you reasonable or in accord with your needs, you need to speak up.
Our primary doctor said they need to be cloned.
Okay. Well, thank you for being such a good group. I love the
Well,
questions. This is
Yeah,
great.
thank you.
Good group of people.
Thank you.
So, Chris, you want to just
Yeah,
answer
no,
your
I was
question?
just gonna say, I'm Chris, and I do work with Hospice of North Coast, and I also coordinate our program for Pathways, where we actually help people walk through that advanced care planning process. So in your folder on the left side, you have, thank you, I'll be in touch.
Thank you.
You do have information, obviously from his talk, and as he was talking about being an advocate for yourself, those are some handouts on the left side of the packet that also address that same issue and how to be an advocate for yourself, how to speak up. There's nothing clearer than talking, and it's that old squeaky wheel that does get heard, and that is something that we consistently encourage people to do. On the right side of your packet, I've actually included the information on the pink form, pulse form. I know you've had some information about that here before, but what we have in addition to that is the frequently asked questions and a little bit of a spell out of the differences in advanced directives and why the pulsed form is needed, and it's designed to go hand in hand with that tool. It's not designed to be a checkoff box form. It's designed to have those conversations anticipatory for what maybe your individual healthcare issues may address. It's designed to have that conversation with your doctor, be able to spell out that recipe, so when you do call 911, they are looking for those pulse forms. They've gone through the state, they've gone through emergency system, they are okay to share information, they're okay with all of the HIPAA, all of that has been processed. So that may be for you that is very firm about what you want and you don't want, to get that signed, because that is a physician's order. That will be honored in an emergency situation. Your trust, your will, are your wishes. That's obviously designating who's going to speak for you when you cannot. So those two tools are really designed to go hand in hand. I also included for you the information that was done out of UCLA Medical Center on CPR, cardiopulmonary resuscitation. And so the old DNR form that says do not resuscitate only is important for the cardiopulmonary piece. It has nothing else to do with the hydration. If you want or don't want dialysis, you do or do not ever want to be on a respirator, you can actually define some of your treatment wishes into limitations, and that's what that's designed and spelled out for. And I would be happy to speak with any of you individually or in a group about how this form works. There's been a lot of misinformation. We've been alive here in California going on 4 years. And San Diego is very proactive as far as using the pulse forms. And those of you here in residential care are the planners. You know, we kind of have two kinds of families that want to plan ahead, and the others, everything's in the file drawer. And it's the greatest gift that you can give all of your loved ones, is to think out loud of what you would or would not want to do, so they're never in an emergency situation making those end-of-life decisions. And that's really the goal, is communicating your end-of-life wishes. Any other questions?
Do you take these forms with you when you travel?
Actually, the recommendation is that the original is designed to stay with you. It is your document. I have many, I tell them make about 10 copies, because faxes and scans and white copies and any other color that you put in print is okay. And I have everybody share it with all of their loved ones. I actually have some that have emailed them to their children, and they actually have scanned them on their iPhones, so that they're in an emergency situation, they can actually roll up that information and say, hey, this is what mom wants, this is when we had the discussion, I have durable power of attorney for healthcare. So there's no registry within the system yet. Kaiser, you said you were at Kaiser Health, they've actually integrating the Pulse into a lot of their healthcare decision making. They kind of have their own version. It's a national program, it's not just here in our state.
If
Our
they've done that, they haven't told their patients.
Well, and that's a big possibility too, and it's one of those things of having the conversation. We're actually encouraging physicians to talk to their families, talk to their patients at least on an annual basis, and that gives them an excuse to bring it out and say, can we have this conversation? I just need to know. They're not going to be there in the 911, they're not going to be there in the emergency room, but if a hospitalist picks the phone up and calls one, which we always hope they do, that way we start engaging in the communication. Yes?
So this would be something to put in our vial of life.
It's something actually a lot of people like the Vial of Life, put it on the refrigerator, some of them aren't magnetized anymore, on the back of the doors. Copies to, as I said, all your loved ones, the healthcare center here, all of your family. I have people that are still driving that have them. The form is really designed when you're medically fragile, and many people are, many people aren't. It's a bit of a gray zone. Are we all medically fragile at times? But it's more of those that have a lot of chronic diseases.
I think, I'm also with Kaiser, and we filled out the forms, and one of the copies is here with our facility and with our nurses.
Excellent.
And the other one is with Kaiser.
Good.
So they've got it on there.
And in communities like this, if there is a 911, they pull all the health records, you know, they pull your med list, unless you're independent and you know, are not using the healthcare center. So I encourage all of you to have your own records, and at least in an envelope, have your will, your trust, your pulse, put your contact information, list who your durable power of attorney is for healthcare, who your physicians are, whether it's in a notebook packet. And a lot of it is in vial life.
All of it.
Yeah, but not everybody has those.
Everybody here.
Everybody here has those? Oh, that's wonderful. That's wonderful. Any other questions? We thank you for your time. Dr. Savage has dashed out the door, but appreciate. Any other questions about anything? Okay, we've given you lots of information to look at.
It's complicated to die, isn't it?
It isn't really complicated to die, but it can be, you know, overwhelming to think about it, and, you know, people usually want to make sure that they're comfortable, and that's really what hospice and palliative care are about. So thank you so much.
Thank you.